A very warm welcome to everyone. Thank you for joining us today. It's nice to see some familiar names. My name is Katja, and I will be serving as your moderator today. So in addition to our learning objectives for this office hour, we would like to highlight that the content of this office hour aligns with the clinical leader's core competencies, and specifically those of general and basic operations, personnel management and teamwork, and resiliency and joy in work. And I'm delighted to introduce to you your faculty, Tammy Green, who is currently the CEO of Anchorage Neighborhood Health Center in Alaska. She's an experienced CEO with demonstrated history of working in the healthcare industry and skilled in leadership development, strategic planning, organizational turnaround, executive coaching, and team building. Tammy has over 25 years of experience in the healthcare arena, including both the public and private sector. Her passion and expertise is in creating and implementing leadership development strategies that support an organizational growth mindset. Additionally, Tammy believes that infusing well-being into everything we do as leaders is foundational to creating a successful and engaged workforce. Tammy's mantra is, which I love, lead like you want to be led, serve like you want to be served, and show gratitude for everything you are privileged to experience. So we believe you will be just as inspired as we are by Tammy's daring leadership and innovative provider leadership model that yields profound value of investment. Tammy eloquently makes the case for reevaluating old paradigms and embracing change with vulnerability to change from a historic to an impactful model that reduces provider burnout and increases retention. You will see shining through the presentation Tammy's and her team's genuine caring for each other's well-being. So thank you, and I'll now hand it over to Tammy. I'll be monitoring the chat, so please feel free to ask your questions at any time. Tammy will be happy to address them throughout, and I will alert her to your questions should she not see them while she is presenting. Thank you, Tammy.
Oh, thank you. That was wonderful. Thank you. I really appreciate the warm and kind introduction. Well, hello, everyone, and greetings from the Northland. I think we're a little cooler than maybe some of you guys are across the country, but it's an honor and a privilege to be here to speak with you. I think of all of you as my coworkers and my co-peers in this journey. And so I'm going to share with you today some things that we've been doing here at Anchorage Neighborhood Health Center. And I would like to just preface up front that, you know, I don't have all the answers, and I'm not saying that what I'm going to share with you is, you know, beyond the pale of innovation, but it's been something that has been really helpful for us in our center. And I really appreciate the opportunity to share with you. And I also just want to acknowledge all of you out there. I can't see you, but I feel your energy. I just want to acknowledge all the hard work that each and every one of you do every day, because being in the community health center world is a privilege, but it is also sometimes really incredibly hard work. So I think as colleagues, the more we can share with each other and create that kind of partnership is just always really helpful. So I hope that you find some of the information I'll share today informational, maybe a little bit inspire you to look at things a little bit differently. And then I look forward to any questions that you have, either that I can answer today through the webinar or afterwards if I'm unable to get to all of your questions. So you can see kind of from the title of the slide, we just want to look forward to what the next practice might be as we look at leadership. And as Katja said, you know, one of the things that I'm really passionate about through my career has been around leadership development and how we really, in a positive way, disrupt what we typically have and be able to step into a space of let's look at what might be possible or what might be different. So we'll start, and the slide presentation will help me kind of stay on track because I get really excited about this work, and so I might veer off a little bit here and there, but I'll try to stay as concise as I can with the presentation. So thank you very much. So these are the learning objectives that we're going to hopefully cover today. By the end of this presentation, I hope that you'll be able to really describe and understand what a distributed shared leadership model looks like and how it can help prevent burnout and increase retention and recruitment efforts. I hope that you'll also learn how the traditional CMO leadership model may be outdated paradigm. And many of you may already have some of these things that you're doing. So again, I don't claim to be on the forefront of knowing everything, but just really want to share what we've been doing and what's been working for us. And then I hope you'll also be able to help us all understand what the next generation of provider leaders are looking for in leadership roles, because it is different, I think, from my generation for sure. And I think as leaders, CEOs, CMOs in these organizations, that the more we can attune to that, the better we'll be able to do in terms of not only recruitment, but retention. And then finally, excuse me, we're going to identify the tools that you need to use in exploring this model in your health center. Next slide, please. So I want to start with what our journey here at Anchorage Neighborhood Health Center has been. So I started 6 years ago in June of 2015, and when I got here, they had a massive turnover, and we only had, I think, maybe 5 providers, and our capacity is somewhere around 35 to 40. Given we were full capacity, so it was like, whoa, got to get in here and figure out what's happening. So there were multiple factors that had influenced that turnover, but over time we were able to recruit and to get providers on board, and really started to see more of a steady, engagement of our providers, and going along feeling like things were good. And then in 2018 and 2019, we had another substantial kind of turnover. And so at this point, I've been here, for about 3 years, and have really a great team that I was working with, the executive team. And I said, we really need to look at what's happening and really start to try to get at some of the root causes and look at a little bit of innovation, or a lot of innovation, in how we might look at what's happening around us. Next slide, please. So with that, we started to look at what could we do to really look at this more objectively, both quantitatively and qualitatively. So I engaged an outside consulting firm that I had actually worked with when I was at Providence Health and Services, big healthcare on the West Coast, that I was with before joining the Neighborhood Health Center as CEO. And so when I talked with the consultant, I said, I want to really understand what our providers, what they need, what they want, what their level of satisfaction is, just really trying to get at the core of what may be causing some of the turnover. So as they met with all of the providers, did one-on-one interviews and some focus groups, the result was a little bit surprising, but maybe not if I kind of stood back and looked at it. It wasn't the money, because we had really worked hard to try to get our compensation structure and strategy really in alignment, and being as competitive as we could with our local healthcare providers. We also have here in Alaska a huge Alaska Native healthcare system. So we are in competition, quite substantially with those around us. So we put a lot of effort into looking at our compensation structure. So the overall theme was that it wasn't money, it was really that they wanted more time. And I know that many of you probably already have done this model, but for us, the model at that time was that a full-time FTE was based on 36 clinic hours and 4 admin hours. Now, if you were an FPOB, at that time it was 32 clinic hours and 8 admin hours. So what we did was we started talking to our providers and just kind of gathering more information. And so I said, you know what, to my executive team, I think we really need to first off start with a model that is much more amenable to what the providers are probably looking for. And so I did some investigation, called around some of the CEOs and other health centers that I knew to see what others were doing. And some were doing this, but most of them were still at that 36 clinic hours as an FTE. So we put together a proposal that said that, you know, we would look at 32 clinic hours and 8 admin as a full-time. And then if you were an FPOB, a family practice doing obstetrics, it would be 28 and 12. Next slide, please. So with that, as you can imagine, we were right in the middle. Our fiscal year is July 1 through June 30. So when that was all going on, I knew we had to really be prepared to bring this to our board because it was going to be a substantive change in terms of our fiscal model. I also knew that we really needed to understand the fiscal sustainability of this new FTE model and what those productivity goals were that were going to have to make it work. So I spent time with my CFO. We went through a whole process of looking at what that would look like and what the, you know, kind of what the minimum level of productivity would be to really have that model work for us. And then what happened was we got all of that kind of laid out, and then I started having one-on-one meetings with every single provider that we had to discuss their buy-in and support and their commitment to the productivity goals that were going to be necessary in the new FTE model. And the thing was, they weren't that far off from what we had expectations around before, but we had not really you know, had a formalized approach to the expectation with our providers. So in all of these meetings, you know, it was very evident to me that the providers were obviously, they were on board and they were all in agreement that they could meet those productivity goals. And so the goals for the model that we built our fiscal model around was that all the providers would, you know, agree that the goal was 16 patients seen per day, 8 patients per session. We do 2 4-hour sessions per day. So once we had all of that built out and had the fiscal model built around it, then we were ready to take it to the board with our annual budget for 2021. So it was quite an opportunity with our board to help them understand why this was important that we were looking at doing this, and that, it, you know, remember one of the board members said, so you're going to reduce their hours and pay them the same. And I said, yes, that's what we're doing. And there was a lot of like, well, how does that work? And so, you know, it was an opportunity to help the board really understand the impact that turnover has, not only from a fiscal perspective, but really from access. It really reduces our capacity to serve our community from an access perspective. So with a lot of conversation and education, the board came on board, quote unquote, and passed the budget for 2021, and the new model was set to go into effect in January of 2020. Along with that, we redid all of the professional services agreements. That's the agreements that we have with our providers. We don't use contracts, we use professional services agreements, but we redid everybody's professional service agreement. And then additionally, we looked at the provider handbook that we had at the time and really determined that it was very lacking in terms of detail and important information. So we completely redid that provider handbook, and it's really a great tool now that our providers have really appreciated. Next slide, please.
Tammy, there is a question Tammy, before you move on to the next slide, and you may be answering this question soon, but there is a question from Craig in the chat. Why the difference for FP, just FPOBs?
Oh, okay. Thank you for that question. I really appreciate. Just interrupt me. Yes. I get all excited on the roll. No, Craig, thank you for the question. So, the FP or family practice physicians and providers, the FPOB are family practice docs that also deliver babies. So, because they're in the hospital and delivering babies, their schedule has always been, you know, about 1 session less than our family practice doc. So hopefully that makes sense. And then he says, another question, 16 patients per day for 4 days. So it's 16 patients per day for a full FTE for 4 days. Yes, that's a full-time FTE. Thank you for those questions. I really appreciate that. And I'll try to glance over to see if I can make sure I'm doing that as well. So the new FTE model went into effect on January 1st of 2020, and that was just when we were starting to hear rumors of this growing epidemic that was out there called coronavirus. And so we were using our visit counts and really looking at what was happening in our productivity metric and looking at what was happening, with the new model. And so January and February, we were actually on track with our budgetary projections for the year. And then it happened in March of 2020. We all know what that was, that the pandemic hit, and then everything turned upside down. Next slide, please. So in 2020, that became the year of COVID-19 for everyone, and also for us for a CMO transition. We had a CMO who had been with us for about 3 years, and he was really terrific. But what was starting to happen, and I was seeing particularly in within the providers as well as the executive team, as all of you totally experienced as well, was those levels of stress really increasing. And I was watching the CMO just really struggling with really trying to manage all of the things that were going, and his family was not in Alaska. They were in another state and were also, suffering some of the consequences of COVID. So I started to watch him moving away from really being in that space of a really engaged CMO. And so he and I had many discussions, and I knew that it was probably just a matter of time before he was ready. He was going to be transitioning out of that role. So I was prepared a bit, but it's still always, kind of a shock to you when that happens, because it is a major transition, when that happens. So starting in the summer of 2020, I knew that he was really in that process of wanting to transition by the end of the year. So with that, as you guys probably know, next slide, please, seeking a new CMO in the midst of a pandemic was really a challenge in and of itself. And so we had hired a recruiting firm that we had before, that actually was the firm that we found our other CMO with. And it went on for about 2-3 months, and we just were not seeing any kind of recruitment coming through. We talked to a few people. And so in the fall, I started thinking, I'm going to go back, because I talked to some of our internal providers, physicians, but they were all said no, they weren't interested. And so when we were not seeing kind of any uptake in this recruitment, I thought, okay, I'm going to go back and really talk to some of our emerging leaders that I had really been watching over the years that I thought could be really great candidates for the CMO role. And so as I went back and started talking to a couple of these folks, they were very clear. They were like, nope, I'm not really interested in that role. It's very demanding, and I'm just not interested. So with that kind of catalyst, I started saying, okay, I wonder what we could do internally to really, kind of look at this role in a very different way that could better serve the CMO, the new CMO, whoever that is, as well as the organization's needs. Next slide, please. So one of the things that I really started to look at in talking to providers, and I'll get to this in a little bit, every year I do conversational interviews with every one of our providers. It takes me about 2 months, but I do a sit down of an hour with each of our providers. Just as a CEO, for me, it's really important to understand what they're thinking and kind of what's going on in at the ground level, if you will. And so one of the things I'd heard over time was that they felt like with the CMO that there was not the engagement there that they needed as providers to really help support them, and particularly from a burnout perspective. So the other thing that I started understanding from talking to a couple of the really high potential leaders that I was really interested in helping them move into a leadership role was that they felt like the current model as well, the demands on the CMO really limited the CMO to really seeing patients. And many of them were still very young in their career and didn't want to, give up the patient care at the level that the traditional CMO in our organization, the way that role had been constructed. The other thing was that they really felt like they needed more balance and collaboration with the CMO from that perspective of, rather than just I'm at the top as a CMO kind of telling everybody what's doing, but how to have a different kind of relationship with that CMO. And then the fourth thing we did was I really started a really intentional process to really look at all of the buckets of work that were associated with the CMO's job specifically, as well as the oversight of things that the CMO was responsible for. Next slide, please. Let's see. Somebody said, how does this play into telemed? I'll try to speak to that in just a little bit later, if that's okay.
Yes, and there was another question on productivity as well. So we have a few questions. One was still about productivity. Is the expectation 16 patients per day, same for all specialties, or is this referring mainly to family medicine providers?
Yes, and in our clinic, we only have, we had a couple of specialists. We had a cardiologist that was very minimal, that they only came once a month, and an addiction medicine specialist. So those are, the addiction medicine specialist is a little bit of a different productivity model for sure.
Yeah,
I'm trying to look over here and see.
Yes, I think some of the questions you can see, Tammy. So there's a question from David. What were the CMO responsibilities that scared everyone else away? How did they divide their time between clinical and administrative?
Yes, yes, and I will answer from from our perspective. So it may not apply to all of you, but let me just see here really quick. Let me get to that in just a second, so I can kind of finish this one train of thought, and then I will, because I'm going to get to that conversation about what those clinical buckets were for that. I just wanted to kind of finish up that one of the things that I also found from all the interviews that I do with every one of the providers. This year I added a couple more questions, but some of the themes that emerged from the interview sections from all of the providers, particularly when we were looking for, what they were looking for in a new CMO. Next slide, please. Were things that I think were really important for us to look at, particularly as we were looking at the new CMO model. So in that space, I had identified a new CMO or an interim CMO from one of our folks who was one of the emerging leaders that I had really kind of been monitoring, watching over several years, and felt like she had all the natural attributes to really step into that role. So as I met with all the providers over that time back in January of 21, I was asking them questions around, what are those things that you see that are really important from your perspective as a new CMO leader. And so these were some of the themes that really emerged. Number one was that they first of all said to me that having that new FTE model that went into effect right before the pandemic was hugely important, and every single one of them called that out as something that really helped them with their burnout and helped them to stay with the organization. We didn't lose any physicians or providers up until like toward the fall of 2021. So, excuse me, 2020. The second thing that they said that they wanted to have a greater voice at the table. And I think traditionally the way that we had the model, the CMO was, over all of these different providers, and really, for many reasons, had more of a kind of, here's how we do it, and kind of trickle down the information. There was lots of ad hoc committees and other things that were under him, but there wasn't really a formalized way that we were looking at a feedback loop to get the voices of all the providers back up to the CMO, and then eventually up to the C-suite, where some of the decisions, were really important that had to be made at the C-suite level. The other thing that, we talked about what they were looking for. And again, I would say the bulk of our providers are in their, early mid-career, somewhere between 35 and 45. That's kind of the bandwidth or age group that most of our providers are in. So the other traits they were looking for, they wanted to make sure that the CMO had obviously missional passion for patient health. They really valued the relationship part of their job as a priority. They wanted a CMO who was able to have relationships with them as individuals as well as providers. They wanted more authentic and vulnerable kinds of communication in strategies and just engagement. They wanted more listening from the CMO, and they also, I thought this one was really great, they wanted the CMO to also have a really genuine care and concern for the broader staff well-being. So not just providers, but they wanted them to understand the team and all of the other ancillary services and the importance of that. They also said that they recognized that the traditional approach to the CMO leadership model had not really been working at ANHC, and they felt bad for the current CMO, who they felt like also was kind of burdened with lots of different things in that role without a lot of additional kind of spread of the leadership. Next slide, please. So we took all of that into account, and when I sat down with the interim CMO, I said to her, I said, so what would make you or encourage you or influence you to really take this role in a much more permanent way? And so she said, well, I definitely want to make sure I still have, 2 days a week to see patients. I want to be engaged in all of these pieces that I see that the CMO is doing, but I really also want to have more, help in this arena. So I kind of sat down and looked at all the different things that were under the CMO's kind of workload, if you will, and really tried to say or look at where we had already created some small buckets of leadership and accountability for other pieces, but then looking at what other things were under the CMO's purview, that if we spread that leadership out a little bit or created more of a true distributed leadership program, there might be opportunities not only for more satisfaction for the CMO, but also to really create opportunities in the broader provider population. So this is kind of what our little leadership model looks like currently with our new CMO. So she oversees our quality program as well as our behavioral health, all the physicians, PAs, nurse practitioners, and the nutritionists. And then underneath that, we created these clinical director roles to help take on some of the other pieces of leadership that then the CMO is over, but she is not herself having to kind of manage all of those pieces at that depth level. And we also knew that things were, kind of falling through the cracks as well, because this one person couldn't do all these pieces. Okay, next slide, please. So with that new model, what we did was we already had a perinatal OB clinical director. We also had an Hep C clinical director and also a Ryan White clinical director. Each of these roles, even though the word director, they're small, and I'll talk to you a little bit about what those hours look like. So those were 3 roles that we currently had, but what was interesting is that all 3 of those roles really operated in silos. They oversaw those particular programs. They sent out information. They engaged with other providers, but they were not connected with each other or with the CMO in a really meaningful way. So what we decided to do is, as we looked at all those buckets of work from the CMO was also over, our lab. We have a full on-site laboratory here in our clinic. We had also just really enhanced our employee health and infection control program. When COVID hit, we were already in the process of looking at bringing on an RN for employee health and infection control. So that was also falling under the CMO in terms of their oversight of that. So we carved out that as another area of a directorship role. And then we also have carved out a director or a deputy medical chief role, but we haven't put that in place yet because we're really trying to understand what the need is from this new chief medical officer who's now been in the role for about 5 months now. And then also we've always had a director of integrated behavioral health, but again, they've kind of been on their own silo doing their own work. So the idea was then, next slide, please, that we wanted to really formalize this work that was going to be happening from a perspective of, instead of just having all these siloed roles that reported to the CMO, but how do you take all of those roles and really have an intentionality around creating leverage from the different roles. So we created formal job descriptions and roles for each of the director roles. We had some kind of, the job descriptions were fairly old. From years ago, from the 3 initial roles, but we formatted and worked with HR to just formalize all of those roles so that they all had the same kind of approach to them. And then the job duties for the director work comprises of 4 to 6 hours a week for most roles, similar to a 4-hour patient session. And then the current compensation model is through a stipend, and that way it also helps eliminate the less access to care. So those were all the things that we did to kind of build out that model. The director of behavioral health is a full-time role, as it obviously oversees a staff of 6 and is a much more formalized full-time role. Okay, next slide, please. So out of that, then what I wanted to do is to figure out how to create something that was much more formalized in terms of this group of leaders, small leaders within the clinic. And so what we did was we looked at taking all of these roles and creating what I came up with was just this provider leadership council. And the idea there was so that we created this council of these leaders that were doing these various roles within the clinic in order to create a formalized way that we were approaching issues and challenges, policies, procedures, practices, all of those sorts of things. In the past, we've had many ad hoc kind of committees that have operated, with different projects or things like that. But what we were finding is that the continuity was really difficult sometimes, because sometimes you would have some providers that came to a meeting 1 month and then the next month they weren't able to come. And so the way that things were kind of getting done was really inconsistent, and it wasn't there wasn't an opportunity to kind of memorialize and codify all the different pieces that that were coming together in those different meetings. So the idea of the Leadership Council was to really kind of take this new model and embed it in a much more structured and formalized way. Okay, next slide, please. I'm just going to stop for a second. I saw Craig's question says that the executive assistant role seems key. A lot of CMOs don't have that. Yes, that was another thing we did about 2 years ago, and that role does not just serve the CMO, it serves the CMO and the COO, which are 2 large roles in our center. But we have found that has been really, really instrumental as well. So thank you for pointing that out. That is a new addition that we did a couple of years ago. So really appreciate that call out, Craig. Thank you. So anyway, just back to the provider leadership model, what we wanted to do was really try to be intentional about really moving toward creating a truer distributed leadership model so that we could not only support the CMO, but also in my mind, it was a way to start to also develop leaders that were, you spread out this leadership in a much more flattened way. It also creates the opportunity to have kind of a little bit of a pipeline to leadership. It also creates the opportunity so that the CMO, if they leave again, that you have some of this work much more distributed so that you're not in that space where you're thinking, oh my gosh, the CMO has left. Now we have a little bit of chaos. Maybe there's other ways that you guys have planned for that, but for us, that was something that became, fairly clear when our last CMO CMO was leaving, was that there was a lot of work and things that just really, only he was overseeing or knew about. So again, this new model has been an opportunity to help us really create this distributed way that we see leadership. And really importantly for me is to create small leadership roles for many of the providers so that they can have an experience in leadership in what I think of as digestible pieces, so that they may decide, oh, I'm going to look forward, maybe I want to move into that, a CMO space down the road. But it gives us the opportunity to not only create opportunities, but then also to help provide training and leadership development for those leaders. Next slide, please. This is just a little, visual of what the model looks like. Next slide, please. And then I just want to quickly, so as we put this together, it was really important for this council to have really clear goals, roles, and expectations. So one of the things that I thought was really important, and the new CMO really agreed, is that it gave us the opportunity to leverage groupthink, gain a broader perspective, and enhance a circle of psychological safety between the members of this group, and to really create that kind of bonding that really allows them to see that they have a different level of ownership in our health center, different from just being a deliverer, a provider that delivers great individual care, but now they have an opportunity to kind of pull up to a little bit of a different level and see their impact in a little bit of a different way. It also helps us with really leveraging our integrated care model when we have all these different folks together to really talk about how we do things differently and what those areas of opportunity are. The other thing that I felt like was really important is that it also gives us this much more clear way to have distributed champions throughout the organization. So now if you're in a small leadership role and you're in your pod or wherever you're delivering care, and you hear folks talking about things that maybe are not going well or things that need to be, that could be better, you now have kind of this role and this expectation to hear that and now be a voice to bring that to the leadership council, bring it to the CMO, bring it to the COO or operations group, so that we now have, I think we have a more robust opportunity to bring what's needed on the floor up to the places where there can be more organizational resources given to those issues, or just, bringing it to the attention of the CMO or the C-suite. And again, it really creates that intentional feedback loop to allow for ideas and requests to not only flow up, but as importantly, to flow back to those folks who have brought those forward. Next slide, please. So one of the things that we've done, and we just have finalized this, is we've created a council charter that provides structure and formalized intention. And again, as I mentioned at the beginning, part of the reason of having this structured approach is that it creates this intentionality and formalization around this work. And it also, more importantly, it memorializes decisions with intentionality through strong documentation. I don't know if you guys have experienced this, but a lot of times when we have had ad hoc committees or subcommittees, they do great work and they help us move things forward. But sometimes if you don't have a really clear strategy or a way to document and really codify some of those things, they don't always get carried out or implemented. And then finally, the other pieces are that we think that by having this model, we're able to really have a conduit to really increase leadership development through experience and mentorship, and also learning about how to be a leader, because most of us don't just end up in a leadership role with all of the skills and attributes to really be great leaders. So having this ability in this group this council setting to bring leadership development to the group, it again supports their own growth and development, and it also supports our approach as a culture, an organizational culture, to really looking at leadership in a very different way. Culturally, you know, from the old paradigm of kind of command and control to this much more deliberate, distributed leadership model with a collaborative approach to how we do leadership. Next slide, please. And then these are some of the things that we have on the horizon. As I said, you know, helping create a development model for these folks. So what we're working on now is this curriculum for the development of these leaders in the Leadership Council. We're looking at emotional intelligence as really one of the most important things that we prioritize and how we weave that throughout this proposed curriculum. We're focusing our curriculum on kind of 5 key skills and 5 key attributes. We're looking at communication, polarity navigation, staff development, crisis navigation, and time management as kind of those key skills that we want these leaders to help. We want to help these leaders develop. And then the attributes that we value here with all of our leadership roles are self-awareness, humility, courage, curiosity, and vulnerability. So we're weaving those pieces into this leadership development curriculum that we are in the process of building out. Next slide, please. And then I think the other piece is that, you know, oftentimes we talk about ROI, which is the return on investment, which is obviously really important. And as a CMO and a CEO, we always are making sure that we're, you know, balancing mission and margin, making sure that whatever we're doing for the right reasons and really being attentive to, that we also can support that on the business side. So when I look at the value of investment, which is a little bit different than the ROI, these are the things that I think are important and that I have used as I talk to my board and others about why it's important that we continue to challenge ourselves to be disruptive and to look at the ways that we currently do things and to step outside of our old boxes. So these are some of the things that I have seen that I know are really important in the value of investment kind of arena, if you will. So I think it allows us to have a competitive recruitment, and because now the providers are seeing that we're trying to have some innovation around the things that we're doing. It's really helping us with increased retention and decreasing our turnover. And the other thing that we're seeing too is it's also helping to decrease the FTE reduction. I'm sure many of you have also seen this, that, you know, in order to kind of decrease burnout, some providers say, I no longer want to be a 1 point FTE, I want to move to a 0.8 or 0.5. So the more that we can create the support around them so that they want to stay at those higher levels of FTE, the better it is for our engagement and our access. Increases joy in practice and satisfaction. It helps us become a reputation as an employer of choice. We think it increases resilience. It also, we think, it helps decrease the burnout for the providers who are actually engaged in some of these small leadership roles. They've all told me that it's kind of nice to have the ability to do something, you know, that stretches their brain in some different ways rather than just, you know, in that direct patient care. And I hope it also really increases everyone's appetite for innovation and change adoption and just being willing to look at how do we look at something different or something that's not in our old paradigm or our norm. All right, next slide, please. And I'm going to look over here. Craig, you've got great questions. I really appreciate them. He says, is the nursing leader a part of the Leadership Council, or are they under the CMO or clinic or directors? The director of nursing in our center is under our COO, our Chief Operations Officer, as well as our and so is our practice director of practice management. But there is absolutely a connection to this group. And since we're fairly new in starting this group, one of the things that we have also talked about is that there are opportunities where we will bring others in depending on what the agenda or the conversations are during that period of time. But I think that those are things that we absolutely see as imperative in terms of making those connections across the organization. So she says, are we actively measuring burnout and satisfaction with a particular tool? Currently, well, a few years ago, we were doing that with another tool, but we're in the process right now of exploring a couple of the tools, one of them being from the Mayo Clinic. So that is one of the things that we're looking at, doing here, I would say, in the next few months. Additionally, we have we do an employee engagement survey every quarter with all of our employees, and we're able to kind of break out the providers as a, kind of as a group. And so there's some measures in there that we're currently looking at using as benchmark, but definitely looking to figure out how we can have a much more robust measurement of our burnout. If anyone has tools that they're using, I'd appreciate anything to be put into the chat box over there. So thank you for that. So, of course, the big thing is affordability and sustainability. And these are the things that we've used to really manage our sustainability model. We know our current CMO is, seeing more patients than the historic model. We also have really factored in the cost of turnover, a decrease in turnover and reduction of FTE, and also, as that, clearly relates to lost productivity and financial burden as well as patient access. We think that the deeper the engagement of all providers and that they see that they have more voice at the table, that again, this is going to be an opportunity to hopefully catalyze them to bring more things forward and to be more willing to be engaged in some of our innovation things that we're bringing forward. Our meetings occur during the lunch hour to provide minimal impact to patient care. We provide lunch to the providers, and also we make sure that the executive assistant is there. She takes notes. Everything gets really formalized, and then everything gets turned right back around very quickly so that the decisions that are made are really, able to get out and communicated very quickly and effectively. And then we believe that this will also increase higher levels of overall engagement and joy in practice. So next slide, please. So our next steps are, we've launched the council. We've had 3 meetings now, and just from talking to the folks, everybody seems to be really excited. We've already, the CMO's already gotten through a couple of major things that she's been trying to work on by herself, and so this group has also been really helpful in, providing her feedback and getting information kind of vetted and translated so that it can be sent out to all the providers. And then our next steps are really looking at benchmarking the burnouts that we talked about, as well as really launching a more formalized leadership training and mentorship program with those leaders that are part of this council. And then the other thing that I have found as CEO that's been incredibly valuable for me is the continued annual interviews and conversations that I have with providers every single year. So that concludes kind of the talking head portion. I really appreciate all of the information, of the questions over here. But any questions that are coming in over here, I can look at it. There's my information. If you have some specific questions that you think about or you want me to answer, I'd be happy to try to do that offline if your question didn't get answered. But again, I just, really appreciate the opportunity to share what we're doing. It's not like we have all the answers or that we have it all figured out, but I just, think that it's important to share things with each other, and then, any feedback that you guys give me and the other things you're doing are very much appreciated, and I appreciate the opportunity to share with you today. So let me see if there's any questions I can answer over here.
There's another one from Anita about the productivity expectations.
Yes, so that is for a full-time. Yeah, that's. And we just, when we build our budgets for our revenue projections, we build our budgets not, we don't build our budgets on 16 patients, as part of what we build our revenue because, there are no shows and things like that. But that is our goal for all of our providers. And our average is somewhere around, in actuality, somewhere between 14.5 and 15. So those are things that we are kind of tweaking as we go along, but we just built our new budget. And this is the first year that we've had our budget, the full budget built on this new FTE model. And we're really, it looks good. So we're making it work right now.
Yeah, and then Matthew is sharing about a similar model they have built.
Let's see. Trying to pull it down here myself.
Yeah, he said that he's curious how you handle performance evaluation of the clinical directors in their director roles versus patient care roles.
So that's a great question. We've been, like I would say, over the last, since I've been here, we've kind of iterated our overall performance management process just in general with our providers. And with our new CMO, that's one of the things she and I are working on right now. We do our reviews and our performance reviews in the fall. So we're really looking at that whole performance process that we're doing currently and really looking to revamp it completely, because I think what we've been doing in the past is just a little antiquated, and it's not, I don't think it's as helpful, and it takes a lot of time. So we're trying to really look at that right now. So if you guys have any great models or things that you're using, I would love to see those as well.
Yes, and then question from Kristen. What will be the role and responsibilities of the deputy CMO, and what is the span of control of the CMO and deputy CMO?
Yes, so we've never had a deputy CMO before. And so I just have it as a placeholder in my budget right now. And to be honest, I don't know what that role is really going to entail. And what the CMO and I decided is that we want to have it just as a holding place right now. So as she gets more into her role and we see needs emerge, that then we can decide if we need that or if we don't. So right now I don't have an answer for that. We just have it. I just wanted it as a placeholder in my budget, just so that we could know that it was there, but also knowing that we may not even use it as we kind of move forward.
Yes. Another question.
Yes, please go ahead.
From Disease, do you have staff who are in leadership providers that are working from home, or that are working from home using telemedicine? Are these processes any different for those staff members? And there was an earlier question that also asked about, are the administrative staff expected on site, or is it okay for them to be off site for their administrative work?
Yeah, so during the COVID, we had initially all of our providers were off site doing telemedicine, except our OBs. We did have a small contingent of providers on site to see potential COVID patients and that sort of thing, but the predominant number of our providers were off site. Currently, we brought everybody back on site. We've done remodeling. We've created all the right spaces. So right now, we don't have anybody working off site. All of us administrators, we were on site every single day. We might work occasionally from home, just as trying to get something done, but none of the administrative staff were off site during COVID. We were all on site during that. But I would say we started in April and May bringing everybody back, and so now currently all of our entire staff is back on site.
Thank you. We have about 5 minutes left, so time for a few more questions. From Tyler, what resources are you using for key skill development? For example, polarity navigation, crisis navigation.
So polarity navigation, that's something I've been really interested in and using for quite a while with my executive team. There is there's a great book out there that started this called Polarity Management. I did a session on it a few years ago at the Leadership Live Council or Leadership Training for NAC. But what I like about polarity management is that it really helps leaders particularly understand how most of the work that we do is not yes, no, black, white, either or. It's really and both. And so there's some really great resources out there. If you want to just reach out to me individually, I can share some of those with you. And then as the other ones around time, management and crisis management, those are just things that I have over the years identified as really important skill sets, I think, particularly for leaders. And we kind of saw some of that really highlighted through COVID. So a lot of that is just things that I've put together myself over the years. And that's, as we build out this kind of curriculum for our leaders, there's not really anything like I'm buying or purchasing. It's just the way that we've been, and mostly me, have been putting things together over the years that I think are really important from a leadership perspective.
Yes.
Somebody asked about the admin time, if they're able to do it at home. We don't make any, if they want to do it at home, they can. They're able to do it on site as well. We didn't make any restrictions about that.
Mm-hmm. And there's one more follow-up to the productivity-related questions from Cheryl Thompson.
Yeah, I totally agree. From talking to other providers or other people across the country, I've talked to some who said, "Oh, that's what we've always done," and then I've talked to others who, their expectations or productivity numbers are what you were saying, Cheryl, higher numbers. I would say that our PPS rate may be a little bit higher because we are in Alaska, but I'm not 100% sure because I don't know what everybody's PPS rate is, but I just know in Alaska, healthcare in general, everything is a little more expensive here. But like I said, we've just been really being very attentive to the budget and building it out. And, so far for us, it is working, but I know that every health center is different and has different kind of expectations and different kind of financial ways that their budgets are built around. So that probably didn't answer your question really well, but that's kind of what I would say.
Yes, thank you. I just put a resource in the chat that came across our desk at NAC this morning from this month's Health Affairs on zero burnout primary care practices. And from what I could tell from the abstract and just glancing at the study, it shows, it talks about many of the things you're innovating and implementing, Tammy. And so take a look at that, and we'll make it part of our follow-ups as well.
Yeah, and I would just say, first of all, thank you guys for letting me share just, what we've been doing here in our health center. And I know that there's so many variations, across the country with every sector of pieces. But I guess what I would just leave us all with is that no matter what, when we look at productivity and all those numbers, I think it's really important for me as a CEO that I'm always in that space of really, A, trying to understand what's happening with our providers, really trying to be as connected to them as possible, and B, really, being willing to kind of look outside the box to see what other things might be possible in the space of really looking at burnout and really keeping our providers as happy and healthy as possible and happy to be working here with us. So anyway, thank you so much. I really appreciate the opportunity, and anybody feel free to reach out if you have any other questions that you think I might be able to answer.
Thank you, Tammy, and thank you again, everyone, for joining us. Have a great afternoon and evening. And until our next office hour, we'll be back in touch. Thank you.